Shall I start now? Okay. Good afternoon, everyone. Thank you for joining. And my name is Divya, and I'm here to present my final project presentation. Title of my project is the dosimetric impact of beam data precision in multi-target brain stereotactic radiosurgery, the quantitative assessment using independent dose calculation for CyberKnife. Before I proceed further, I would like to sincerely thank my supervisors, Dr. Martin, Mr. Godfrey, and Dr. Pechman as well for helping me and guiding me throughout the project. Thank you. So I'm starting. So just give me a minute. Okay. So the brain metastases. Brain metastases are the secondary brain tumors that originate from primary brain tumors. The common primary sources of the brain metastases are lung cancer, breast cancer, and melanoma. And together, these three account for more than 80% of the total cases of brain metastases. So the treatment options for brain metastasis include surgery, which is mainly for limited, accessible, and large tumors. And another popular treatment is radiation, such as whole brain radiation therapy and stereotactic radiosurgery. And other treatment options are systemic therapies using drugs. Systemic therapies are either used along with surgery or radiation therapy, or when these treatment options are not feasible. So major challenge in treating the brain metastasis is to manage neurocognitive side effects, which can significantly impact the patient's quality of life. So modern approach to treat brain metastasis is the stereotactic radiosurgery. It is increasingly used technique. So it is highly precise and targeted radiation therapy that delivers high dose of radiations to the target while minimizing radiation to the nearby target. So it is replacing the traditionally used whole brain radiation therapy, as it offers the similar survival rates comparable to whole brain radiation therapy with reduced risk of cognitive decline and shorter treatment duration. And stereotactic radiosurgery is the only standalone treatment benefiting patients suffering from multiple brain metastases. So there are many advanced stereotactic radiosurgery delivery system, Gamma Knife, which uses the precise beam of gamma radiation, LINAC-based radiosurgery, which use high energy photon beams, and proton therapy, which use protons to treat tumors. So these three therapy, gamma knife, LINAC, and proton therapy, these delivery system require some fixation devices and masks for the patient immobilization. But CyberKnife is the only frameless stereotactic radiosurgery system where the combination of robotics and real-time imaging enables the system to deliver high doses to the target with sub-millimeter accuracy. And CyberKnife allows the delivery of the multiple brain metastases. Peripheral dose in stereotactic radiosurgery. Peripheral doses in stereotactic radiosurgery are the doses that extend the main treatment field area, and the sources of peripheral doses are the leakage from the LINAC head and leakage and scatter from LINAC head collimators and leaf, and also the intrapatient scattering. So although the peripheral doses are low, but still significant and needs to consider for complex stereotactic radiosurgery where multiple targets are adjacent to each other, and it can contribute dose to the dose to the targets. And it needs to be considered for the complex radiosurgery as it can increase the risk of radiation-induced side effect, and in extreme cases, it can increase the risk of secondary cancer induction. Here is the table of the that lists the studies done by different authors assessing the peripheral dose. Excuse me. Sorry. So here is the table that lists the studies done by different authors, and these authors have assessed the peripheral doses using the different techniques, and the studies that I have highlighted in purple are the studies done by the author, like such as Schneider, Howell, Colonnet, and Huang. So they have assessed the accuracy of the treatment planning system in the out of field region. And in all the studies, they have found that the treatment planning systems are not optimized for out of dose calculations. So background for my project is stereotactic radiosurgery has been increasingly used for the multiple brain metastases, and it can be seen that from the literature that our current treatment planning systems often do not correctly calculate the doses in the out of field regions, and uncertainties in out of dose from one target may contribute to dose to the other target in complex stereotactic radiosurgery. So there is a need for a more refined approach, and in the literature, the studies done by different authors, they have assessed the peripheral dose either by using direct measurements or by using the system upgrades, and then measuring it with the ionization chambers or diodes. So the aim of my project is to assess the dosimetric impact of beam data precision in multi-target brain stereotactic radiosurgery. It includes examining how changes in radiation beam data in peripheral region affect dose calculation across various targets, and also analyzing the dose deviations from treatment planning systems for multiple targets. So the all the plans for the study are from the CyberKnife system at Sir Charles Gardner Hospital, and ethics have been approved by UWA HREC. So the CyberKnife at Sir Charles Gardner Hospital, it produces the 6 MV flattening filter-free beam with a constant dose rate of 1000 monitor units per minute, and it offers the two types of secondary collimator, 12 fixed collimators and 12 iris variable aperture collimators. And it is incorporated with the accuracy precision treatment planning system. And this treatment planning system has 3 dose calculation algorithms: Monte Carlo, ray tracing, and finite size pencil beam for dose calculation. And CyberKnife is calibrated such that 1 monitor units deliver 1 centigrade at 100 mm source to axis distance at a depth of 15 mm in water for a field size of 60 mm. And the treatment plans are selected, the treatment plan selection are for the patients with multi-brain metastasis, and all the plans are plans used fixed bones and 60 skulls tumor tracking method. So the method. So to do this project, so the first step is to scale the original off-center ratio beam data systematically, and then utilizing that modified off-center ratio data for dose calculation using independent dose calculation. So in the first step, how I did the scaling of the off-center ratio data. So off-center ratio data, it's a parameter that defines how the dose varies off the central axis of the radiation beam. So for we have 12 for fixed collimators, we have 12 OC off-center ratio profiles for 12 fixed collimators, and for each of the 12 collimators, these profiles are obtained at 5 depths: 15 mm, 50, 100, 200, and 300 mm. So here you can see the off-center ratio profile of a 5 mm collimator. So in this off-center ratio profile, the X for 5 depths, X represent the radius or the distance from the central axis, and Y represents the corresponding off-center ratio value. So to do the scaling of the off-center ratio profile, so the scaling point, I choose the scaling point for 12 scaling points for 12 off-center ratio data tables. So these points have been carefully chosen. If you can see here for a 5 mm collimator, I have the scaling point, that X value is 3.8. So it has been chosen in such a way that Y is less than or equal to 0.2. So I looked all the off-center ratio tables, and then for each off-center ratio table for each collimator, I chose 12 scaling points, and based on the Y value, 12 scaling points X based on the Y values, which is less than or equal to 0.2, and this scaling point represent where the start point where the scaling of OCR will be done. So the algorithm here is this. So how it works: it loads the CK beam data, and it gets the 5 scaling factor. These 5 scaling factors represent the amount of scaling for the given OCR table. So once it gets the 5 scaling factor, and then it defines the shift point for each OCR table. So I have defined the 12 shift point for 12 OCR table based the X value based on the condition y is less than or equal to 0.2. And after that, the shift points are defined. Shift value, that is Y value, I've set it to fixed 0.2 for all the table. Now now the code loops through the 5 scaling index, that the amount of the scaling defined for the tables, the 5 scaling, and then after loops through 5 scaling, then it loops through 12 OCR tables, and then it loops through 5 depths, and then after it loops through 5 depth, it identify the index of the shift point, the index, the I, where the scaling is to be started. Once it identify the shift point, then it, according to this formula, it shifts the value of y based on the scaling factor and the shift value, which is set 0.2 constant for all the 12 tables. Once it update the y value based on the scaling factor and shift value, it update the off-center ratio table, and it until the end of the table. So after it update the off-center ratio data, it stores the modified off-center ratio data in the structured array, and then stops the algorithm. So this way, by doing this, I have got the plot for the 5 mm collimator. In this 5 mm collimator plot, I have I've defined the 5 scaling: 5%, 10%, 15%, and 20% and 25%. So this is the result I got after applying the code, MATLAB code, to do the scaling of the off-center ratio data. So here the one profile is zoomed. Here you can see that for 15 depth profile, the original off-center ratio data is the blue one, and the 5 scalings are done in this way. So after doing the scaling of the OCR, the next step was the independent dose calculation. And for the independent dose calculation, a new MATLAB code was developed. And this MATLAB code is based on the code by Doric from his book, The Clinical Radiotherapy Physics using MATLAB. So for this code, the input file required are the patient-specific DICOM files. So it includes DICOM CT image series, one DICOM RT structure file, and one DICOM RT dose file. So these are saved for further processing. And the one, it needs one plan XML file, and from this plan XML file, these parameters such as monitor unit, collimator size, node coordinates, target coordinates are extracted for dose calculation. Another XML file is the beam data list XML file, and from this beam data list XML file, the reference point and patient info was extracted for further use. And another input required for the code is the CT calibration data. And this CT calibration data is used to obtain the CT calibration curve. And from this CT calibration curve, two linear functions, one from -1000 to 0 based upon the Hounsfield unit values, and another function from 0 to 8000 were used, and this relation was obtained using these functions to calculate the relative electron density of the of the voxel. So another input required for the code is the original beam data. This is the beam data obtained during the commissioning of the treatment planning system. The beam data is the tissue phantom ratio, output factor, and off-center ratio. The original beam data, tissue phantom ratio, output factor, and off-center ratio using the MATLAB code. These tables are interpolated and extrapolated to ensure the comprehensive coverage for the dose calculation. And after interpolation and extrapolation, these are arranged into the lookup tables. And one more step in the MATLAB coding is the off-center ratio data. It has been scaled to 5 values, 5 scaling factor, 5%, 10%, 15, 20, and 25%. And then after the off-center ratio data has been scaled, it has been interpolated and extrapolated, and it produces 5 additional set of the modified off-center ratio values that we have used for the dose calculation. So after the input, the next step, data has been interpolated in such a way that the tissue phantom ratio, the field size, it covers the field sizes from 5 to 80 mm, and the depth from 0 to 350 mm. And output factor covers the source to axis distance from 500 to 1500 mm. And off-center ratio data covers the depth from 5 to 400 mm and radii from 0 to 80 mm. So next step is the patient model structure and dose cube reconstruction, various DICOM attributes and 2 MATLAB inbuilt functions, the DICOM info and DICOM read and DICOM info has been used to do this step. From the DICOM CT, a 3D CT matrix is obtained, and from the DICOM RT structure, which contains the contour data of all the structures. So a one-dimensional mask of the selected structures has been obtained, and from DICOM RT dose, a 3D dose matrix has been obtained. And this 3D CT matrix and 3D dose matrix has been used to obtain the registered 3D dose matrix, which is used to get the treatment planning system calculated dose. And another one-dimensional mask, along with the 3D CT forms the 3D binary mask, where ones denotes the voxels belonging to the structures and zero otherwise. This way, once the patient model has been reconstructed and the other parameters have been loaded for dose calculation, the next step is voxel addressing and dose calculation. And for voxel addressing and dose calculation, the reference point that we got from the XML, the beam data list XML file, it has been verified among the global Dmax point by checking the dose at this point is equal to normalized dose. Once this reference point is verified, and another step is from 3D mask, we obtain the center of mask of all the selected structures, and using being analytical geometry and relating the general reference conditions to the actual conditions, this beam geometry is used to calculate the off-axis radius, source to axis distance, and effective path length by tracing a voxel from the source to the calculation point and skipping 4 voxels. This way we calculate all the parameters, and once all the parameters once we have all the parameters, a factor-based ray tracing ray tracing algorithm has been used to calculate the dose. So this way, the MATLAB code calculates the dose, and here is I discussed the basic flow of the. Here is the detailed flow diagram of the MATLAB code. So what's the code output? The MATLAB code that calculates the dose. It produces the result in the tabular form. It displaying voxel coordinates and the treatment planning system dose and the independent dose calculation using the unmodified off-center ratio data, and 5 dose calculation values using the 5 modified off-center ratio data, and then it displays the percentage dose difference of these calculated dose from the treatment planning system calculated dose. And another thing, this code, another code output of this code is the axial and sagittal view of the CT with overlays of the selected structures. And it also plots the dose deviations of all the selected structures, deviation with the scaling of the OCR. So this is the MATLAB code output of the code developed in the study. So because I have limited time, so I'm going to include just 2 plans for discussion. This is the result of one plan. This plan, in this plan, the patient has seven brain metastases, and the plan includes 220 beams, and the collimator sizes are 5 mm and 10 mm. If we see the dose deviation plot, all the GTVs in the percentage deviation of all the GTVs with increasing scaling of the OCR is different. All the GTVs shows the different sensitivity to the scaling of OCR. And GTV6, if you see here in the graph, the GTV6 shows the maximum deviation. So the reason that GTV6 showing maximum deviation could be the GTV. It's in the close proximity of another target GTV3 and GTV4. If we see that GTV4 has a higher prescribed dose, and GTV and the size of GTV3 is much larger. So much larger size can contribute more peripheral dose, and the higher GTV4, which has a higher prescribed dose, could have an impact on GTV6. The peripheral dose spill over on GTV6. So it may have resulted in the more deviation for GTV6. Another close proximity is the GTV1 is between GTV1 and GTV2. GTV2 being larger in size may have contributed his peripheral dose to GTV1, resulted in more deviation to GTV1 compared to GTV2. Another plan is where the collimator size of one target is almost double the another target. GTV1 being bigger in size as compared to GTV2, so it delivers higher proportion of peripheral dose, so resulted in more deviation to GTV2 than GTV1. So here is the combined plot of all the GTV across 11 patient plans. So there are 56 GTV lines, and in this plot, so all the lines are clustered around mean, showing a consistent response across most of the patient plans, but still there are lines that are away from the mean. So in the when after analyzing the 11 patient plans, the one thing was noted, the proportional relation was obtained. So all the deviation of all the GTVs with the scaling of OCR was proportional, increasing with increasing scaling. But the another thing was obtained, the differential sensitivity of different GTVs. So here is the table where I have calculated the mean difference in percentage dose deviation between each incremental scaling. And from this table, it can be seen that average GTV shows a differential sensitivity to the changes in off-center ratio data. Impact of target proximity and target size. There was, analyzing 11 patients, analyzing 11 patients, I can say that target proximity and target size impacts the adjacent targets. So they results in contributing more peripheral doses to the adjacent targets. When analyzing 11 patient plans, I did not get any clear relationships between the number of target to the deviations, because in some plans, fewer targets showed more deviation, and in another plan, more targets shows less deviation. So there is a need of more more data to conclude this. So one more thing from this code. So this code can be served to can verify the accuracy, the calculation accuracy of the treatment planning system. Here, with the unmodified OCR, the dose calculated value, the calculated dose values were compared with the treatment planning system dose for all the 11 patients. So this is the graph of all the 11 patients, and from this graph it can be seen that all plan results fall within a tolerance of 5%. So this code can serve as a very independent verification tool to check the accuracy verification of the treatment planning system. So to conclude with, I can say that I can conclude that this study highlights the sensitivity of different GTVs, illustrating the complex ways in which metrical distribution and orientation of GTVs influence treatment outcomes. And furthermore, the code can serve as a vital secondary check, confirming the precision of dose calculated by the treatment planning system. And suggestion is the further analysis using other modified data set, tissue maximum ratio, output factor, and more patient plans can be used to further enhance the study. Thank you.
Thank you very much, Divya. Well done.
Thank you.
We'll open the floor to questions now. So if anyone has any questions, please feel free to put your hand up. Hey, it doesn't look like we have any questions at the moment. I might jump in with one of my own then. Godfrey,
Can you hear me?
You go for it. Yes.
Yeah, thank you very much for the presentation, Divya.
Thank you, Godfrey.
Yes, thank you for the work. And I guess my question is on your statistics, the comment that you're making there about some of them there were fewer met, and some, I mean, the results were not, maybe you could not correlate that because maybe you've got fewer patients. And it's understandable. I guess it's understandable because you're looking at maybe one case. Do you have another thought, how you could have maybe looked at the influence of those meds, if they're more, do you have another thought of how you could have maybe looked at the influence of that?
Yeah, I could have done more on but due to limited time, so I presented. So there were a few more things, that the target geometry and measuring the other things. So I because of the limited time, I couldn't explain more.
Okay.
So I checked the time, so I was running out of time.
Okay.
Hey, Martin, jump in with a question.
Hey, Divya, thanks. That was that. Terrific presentation, thanks. So I guess clinically, we're treating patients and there's some uncertainty about this, how much dose they're getting from the in that penumbra region outside the penumbra. Yeah. Is there what can the clinicians do to compensate for that? Is there anything they can do to account for the fact that there's that uncertainty due to the contribution of scatter?
So one thing could be done based on the results of my code. We can see that how different targets we can get the sensitivity of the different. Some targets are more sensitive and some targets are less sensitive, and by seeing this, we can set a dose tolerance to the targets that are more sensitive to the scaling, and we can set the dose constraints to different targets based on their sensitivities.
Mm-hmm. Sure.
So there were more other things that can also, that's not a part of my study, but the tumor biology and target geometry, these factors needs also to be included to get a better picture of how we can set the tolerance to the different dose tolerance to the different targets.
Okay. Mm-hmm.
Benjamin.
Thanks, Divya. It was a nice presentation.
Thank
Very practical project. Thanks, Martin and Godfrey.
Thank you.
My question from Divya, your investigation was on CyberKnife and plans from CyberKnife. If we want to compare CyberKnife with LINAC, with type of brain metastasis treatment with non-coplanar type of method, what you are expecting? Less peripheral dose or more peripheral dose compared to
the normal LINAC-based steroid?
That's right.
So I'm not sure because throughout my study I studied CyberKnife only, so I didn't get a chance to have a detailed study on LINAC. But I guess that using LINAC could be less peripheral, but I'm not sure.
That's fine. That's thanks.
Thank you.
Divya, so your study sort of centered on, a comparison between a treatment planning dose calculation and the outputs of a specific MATLAB code. I was wondering if there was ever any consideration of doing some actual measurements of the dose, and if you think that would sort of, be a fertile path for future work.
Sorry, I didn't get. Sorry, can you repeat it, please?
Did you consider actually doing some measurements of the dose?
No,
and including that in the study?
No, I didn't. I used a CyberKnife actual beam data, and I used the MATLAB for to do the my project.
Yeah. So do you think your project would have benefited from including some measurements of dose from some actual treatment plans?
Yes, I do understand. But I was when I started the project, and I had many things in my mind, so I wanted to do, but I didn't get much time to do all the things together. But I believe that whatever I have done is enough for my project.
Yeah, no, I understand that. The question is just if you think it would have benefited your project to include some measurements, and if that would be a potential, option for future work.
Yes, I'll consider it for future research, maybe.
Okay. Yes. Thanks, Divya.
Thank you.
Do we have any more questions?
No.
It doesn't look like anyone has their hands up that I can see. Okay. Divya, I think we'll call it there. So thanks very much for the great presentation there, and thank you to everyone else. I'll stop the recording just before I finish off.
Thank you.
Okay, excellent.